Prostate cancer is one of the most serious diseases affecting men. Every year, approximately 4,100 men in the world die from it. Today, it's the second most common cancer in men, while only lung cancer among smokers is more dangerous. Prostate cancer is fully curable. According to international guidelines, there are two treatment options that can completely eradicate the disease. Robert Kennedy, Nelson Mandela, and David Copperfield all chose radiation therapy, while Robert De Niro and Chuck Norris underwent surgery. In this video, I will explain you both methods in simple words and pictures, including their benefits and potential complications. Even better, I will show you how to use an international online calculator that lets you estimate the chance of treatment success. This is exactly what every patient and their family needs to know at the very beginning of their journey. So, once more, prostate cancer can be fully eradicated and forgotten forever, but only if the tumor hasn't spread beyond the prostate gland. According to international guidelines, there are two treatment options. Surgery means complete removal of prostate gland with the tumor, and radiation therapy, precise delivery of high energy beams to destroy cancer cells. But these are two completely different ways. How to choose the right option? Who should make the decision? And most importantly, what happens after treatment? Both methods physically destroy cancer cells, but the choice between them is especially critical in prostate cancer because of two reasons: the prevalence among men and the anatomy. So, let's start with anatomy. The prostate sits between the bladder and the rectum. It's also surrounded by urinary sphincter, which holds urine in, plus nerves and blood vessels, which control both erections and urinary continence. During surgery, the surgeon must carefully separate the prostate from the bladder, the rectum, the sphincter, and the neurovascular bundles, and then reconnect the channel to the bladder, all deep inside the pelvis, in a very tight space. In oncology, all kinds of surgeries are divided into two types: organ sparing, like removing a kidney tumor but keeping the kidney, and organ removing, when we have to take out the tumor with the whole organ. Modern oncology is trying to find a way to safely and effectively remove prostate cancer while saving the prostate gland. But so far this hasn't worked. So the global standard remains complete removal of the prostate with the tumor, and this procedure called radical prostatectomy. Additionally, the procedure typically includes removal of pelvic lymph nodes, which are potential pathways for cancer spread. What happens after surgery? This is the most important question, and we need to be honest with each other. First of all, let me describe you the ideal scenario of the surgery that every patient and surgeon hopes for. This is a planned procedure lasting 2-3 hours, performed either through a small lower abdominal incision, or via laparoscopic approach, or with a surgical robot. I should say that the choice of approach is always up to the surgeon. Large global studies have confirmed that all three techniques give identical cancer control and complication rates. So the method depends on what the surgeon knows best. Yes, robot-assisted surgery has some advantages, but this is a topic for another video. After surgery, the patient usually stays in hospital for 3 to 7 days. The urinary catheter, needed while the connection between the bladder and the channel heals, is removed before discharge. Another 1-2 weeks of sick leave, and then they can return to work. About a week after discharge, there is a follow-up meeting to review the pathology report, the detailed analysis of the removed prostate with the tumor and lymph nodes. This moment is absolutely critical in every patient's life, because the whole point of the surgery is whether the cancer was fully removed or not. Surgical margins. What does it mean? This is the prostate, this is the cancer. Remember, unlike BPH, prostate cancer grows near the capsule, not in the center. And during the surgery, you cannot see the cancer with your eyes, because it doesn't look different from the surrounding tissue. And you cannot be sure during the surgery whether every single cell was removed or not. That's why waiting for the pathology report is so stressful for both doctor and patient. Negative surgical margin, when the entire prostate was removed within healthy tissue, meaning no cancer cells left behind. Positive surgical margin, when the surgeon cut through the tumor and at least one cancer cell left in the body, meaning that the goal of complete removal was not achieved. The next part of the pathology report is the lymph nodes. There are two purposes for lymph node removal: to check if the cancer had already spread at the time of the surgery, and to remove cancer cells if they were there. If lymph nodes are left behind or not fully removed, there is a high chance the cancer could come back, and the patient may need additional radiation therapy after the surgery. Important: lymph nodes are not always removed during surgery. So this is a key point to discuss with the surgeon before the procedure. Ideal pathology result: negative surgical margin and more than 15 lymph nodes removed from each side. If surgical margins are positive, it indicates a need for postoperative radiation therapy to destroy any remaining cancer cells. In such case, patients undergo both radical surgery and radiation therapy, and the associated risk and side effects can build up. Functional outcomes: the second important question when we are talking about treatment of prostate cancer. Everybody wants that everything to work like it did before. But unfortunately, there is no perfect disease and no perfect treatment, especially in oncology. There are two major potential complications for prostatectomy: erectile dysfunction and urinary incontinence. Yet, it sounds terrifying for a man. This happens because during surgery, the prostate must be separated from urinary sphincter, which controls urine, and neurovascular bundles, which control erections. These are extremely delicate structures, so some degree of damage always occurs during procedure. So how can we predict your outcomes before deciding on surgical intervention? There is a special international calculator that estimates your outcomes. Let me show you how it works. You simply enter, for example, that you had no prior hormone or radiation therapy, a 60 years old man with PSA level 4.5, and we also enter prostate biopsy result and clinical stage 1 prostate cancer. The calculator shows only 8 out of 100 men will die from prostate cancer within 15 years. But the chance that surgery alone will cure him without needing additional radiation therapy is only 54% over 5 years. And over 10 years, that drops to 38%. Even before we discuss the underlying causes, you can use the risk calculator yourself just right now. Simply enter your email through the link below or the QR code. You might wonder why surgery has such low effectiveness and a high recurrence rate. There are two main reasons. First is the surgical quality. It's clear because not all surgeons have the same skill or experience. And hidden spread, when even before surgery, microscopic cancer cells may have already spread beyond the prostate, possibly into the lymph nodes, bones, or neurovascular bundles. That's why experienced surgeons often plan ahead. If cancer is near the bundles, they may intentionally remove them to maximize cancer control on one or both sides. But unfortunately, that leads directly to erectile dysfunction and total incontinence. The calculator also estimates probability the cancer is confined to the prostate, risk of extracapsular extension, likelihood of lymph node involvement, and possible invasion of the seminal vesicles. We always discuss these calculator results with the patient and family before choosing treatment. Plus, we must always add from 3 to 7% of general risk from surgery and anesthesia complications. I have 15 years of experience at top oncological clinics, including Hadassah Hospital and European Medical Center. Need to find out your condition or get a second opinion? Link in description below. Radiation therapy, also called radiosurgery. This is a breakthrough in modern medicine, and it's challenging the role of surgery in prostate cancer. Radiosurgery delivers highly focused radiation beams to the prostate and pelvic lymph nodes with surgical precision. Thanks to advanced imaging, planning, and technologies, radiation therapy now not only competes with surgery, but it sometimes makes surgery unnecessary. What does it feel like for the patient? First of all, it's outpatient treatment, no hospital stay. So there is no any surgical or anesthesia risks. Usually it takes around 5 procedures, and the patient can go to work just after treatment. How does it work? After detailed planning and marking, radiation precisely targeted to the prostate and lymph nodes. The full effect builds gradually. Maximum changes happen over the first 3 months, and then treatment continues for a total of 9 to 12 months. Success is measured by PSA level. When PSA reaches its lowest point, we assess the cancer outcome. And now let's talk about side effects. To compare with surgery, there is no urinary incontinence after radiation therapy, because there is no physical cutting of the urinary sphincter. Erectile function. Radiation delivers a full dose to the prostate, but partial dose to the edges, including the neurovascular bundles. Yes, this can reduce erection quality, but remember, if cancer cells have already spread to those bundles, this partial radiation can improve cancer control. Bladder. Mild irritation can cause more frequent urination. Rectum. Radiation proctitis means inflammation of the rectal wall. Usually this may happen within the first 3 months of the therapy and causing increased bowel movement, mild rectal bleeding, discomfort, and diarrhea. But usually these symptoms stabilize and improve over time. And finally, how do you choose between surgery and radiation therapy? This is never a simple discussion. It requires deep expertise and support from specialists, because this is a very first step on your way. Take care and see you soon.